Good afternoon, everyone, and welcome to today's wonderful afternoon with Dr. Murali, where we have a discussion of the full-scale grand test. So every Sunday we have a 200 MCQ ditto actual exam in the same pattern as that of the actual NEETPG. So the spirit of taking this exam is all about how much we could score with no preparation at all. At least 100 out of 200 do we know, or 50 out of 200 do we know. It doesn't matter. Every Sunday we will be improving because we will be finishing one of the other subjects from Monday to Saturday. Right? So every day evening, 6 p.m. to 8 p.m., we have the live discussion of our regular subject review. And on every Sunday, 9 to 12 test and 1 to 3, we have the discussion of the 200 questions. So if you are from Hyderabad, please come down to our Nampally and directly attend live. Thanks to Dr. Girija and Shiva Prasad Reddy, Sai Prasad Reddy from Vishwa Bharati. Vishwa Bharati, yeah? Good. So with that preamble, let's make the great beginning, Doctor. Chorda tympani. Chorda tympani Yeah. Chorda tympani is a branch of the facial nerve. Is a branch of the facial nerve. And you all know that it joins the lingual nerve. It carries the taste from the anterior 2/3 of the tongue. That's what you need to remember about the chorda tympani. The whole of the face, all muscles, what is the motor supply of all muscles of the face? Facial nerve. The only exception, the only muscle in the face which is not supplied by facial nerve is levator palpebrae superioris, which lifts your eyelid, which is supplied by the oculomotor. That's the reason whenever oculomotor nerve palsy is there, your levator palpebrae superioris get affected and you get ptosis. Then the whole of the face sensory supply by trigeminal. And the only area which is an exception is the skin overlying the angle of the mandible. Right? So, please come. So that is the place which is being supplied by great auricular nerve is what you need to remember. Very good to see Dr. Teja. Yeah, we had been missing in the evening classes. Please do come. So that's the story. Now, what are the tributaries of the internal jugular vein? You should remember facial vein, lingual vein, superior thyroid vein. They're all the tributaries of the internal jugular vein. You know, you have an external jugular, internal jugular. Both of them will drain into the superior vena cava, which drains into the right atrium, as all of you know very well. So how do you remember the tributaries of internal jugular vein? I'm very happy to see 3 online classmates and many more to join. So occipital vein, pharyngeal vein, lingual vein, inferior petrosal vein, facial vein, superior and middle thyroid, not inferior thyroid, superior and middle thyroid veins, they all drain into internal jugular vein is what you need to remember. Once more, this kind of items, no doctor, disgusting items. The internal jugular vein tributaries, blah, blah, blah. But first time you should know, second time you need to remember, and last time before 30 days, you need to bookmark it to revise in the last moment. That is the most simple technique of exam. Medial wall of the orbit. What are all the things that constitute medial wall of the orbit? The orbit has a roof formed by the orbital plate of frontal bone and lesser wing of spheroid. Orbit has a floor, it is formed by 3 bones. The body of the maxilla, the zygomatic bone, and the orbital surface of the palatine bone. Palatine bone. That's what we need to remember. When will the differentiation of the gonads in human fetus, it is complete. So tomorrow when you are an obstetrician, everybody will be asking boy or girl, very difficult. So the best way to say is, I too don't know. Huh? I too don't know. I'm trying to know. Next time we will see. You should tell. So when will boy or girl will be known? 9 weeks. The differentiation of gonads in human fetus is complete by 9 weeks. The gonads are neither male nor female until 7th week of intrauterine life. That's what you need to remember. And once more, all the embryology of the gonad we will discuss in our regular anatomy class. Perennial body. What are the muscles which are attached to the perennial body? Is the favorite question of the examiner. It is the bulbospongiosis. So perennial body is totally formed by 9 muscles. There are superficial transverse perenniae, deep transverse perenniae, pair. So totally 4. 2 sphincters, sexual anal sphincter and sphincter urethrae. Then levator muscle. Typically pubococcygeus and iliococcygeus, but not ischiococcygeus. And bulbospongiosis. This is what you need to emphatically remember. Now, how do you know somebody's vagal tone is good or not? How do you know? Basically, everybody has a basal heart rate. Those who do yoga, their heart rate will be 60, 65. Still, they are not considered to be bradycardia, because those who are athletes and those who do yoga, their parasympathetic tone is very high. And that is the reason their basal heart rate is low. That's what you need to remember. And withdrawal reflex. Typically, withdrawal reflex, whenever you are doing, suppose some pin is there, your foot is touching it, immediately you will withdraw to a noxious stimulus. So it has a long latency, polysynaptic, it has an after discharge. They're all true, but not carried by 1A fibers. Now, what is the story of these fibers? Pain is carried by nociceptive reflex, is carried by the type 3, type 4 fibers, is what you need to remember. Can I check online whether it is clear? So, doctor, what is the nerve fiber classification? Famous question of the examiner. You have A alpha fibers. Under that, you have 1A and 1B fibers. They have a high conduction velocity. 2 points you need to remember for the tomorrow's entrance. 1A fibers are related to muscle spindle. 1B fibers are related to the Golgi tendon organs, is what you have to basically remember. Then A beta fibers are also classified as class 2 fibers. Typically, they are related to the muscle spindle's secondary endings for touch, kinesthesia, etc. A delta fibers are also called class 3 fibers. They are very important for pain and cold temperature, is what you need to understand. Now let us talk about cerebrospinal fluid. So from where is cerebrospinal fluid produced, doctor? Choroid plexus is the one which will be producing the cerebrospinal fluid. And you need to know what is foramina of Monroe, etc., etc. All these funda you need to know. I don't go much deep into it. What is the composition of CSF? How much volume of CSF is produced? Blah, 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 everything. You need to be very sure. Why the tuck-tuck sound is coming? Check that. Is it the local settings anywhere? Loose connection in the... Okay, please. Okay, all right. With regard to the ECG, how do you know that there is a heart block? Heart block is identified by prolongation of the PR interval. So PR interval is the start of the P wave until the start of the QRS complex, where P wave and PR segment together, when you include, it is called interval. Segment is isoelectric line. All right. So don't worry. While teaching general medicine, in 6 hours, I will make you experts in ECG. Anything, everything about ECG, you will be able to know. Just 6 hours of your time for me, right? One of the days we will review that. So first degree heart block is a PR interval more than 0.2 seconds is what you need to remember. And you know, T wave is ventricular repolarization. Repolarization, both of them happen during QT interval. QT interval is QRS complex till the T wave, end of the T wave. T wave represents repolarization, QRS represents depolarization. Together are the part of the QT interval. And what is a normal QT interval? QT interval is always taken in relation to the speed of the heart rate. Square root of RR interval, QT divided by square root of RR interval is called corrected QT interval. Corrected QT interval generally is around 440 milliseconds. If it is more than 600 milliseconds, then it is called prolonged QT interval, is what you have to remember. Testis produces testosterone, dehydroepiandrosterone, androstenedione, but not dihydrotestosterone, which is produced by testosterone converted to dihydrotestosterone. It is a metabolite of testosterone. Phenylketonuria, phenylalanine hydroxylase is deficient. Histamine typically lead to increased gastric secretion. Hence, antihistamines have a role in ranitidine, everything have a role in peptic ulcer. Urea cycle, what is the enzyme commonly deficient? Carbamyl phosphate synthetase 1. See, Dr. Biochemistry is all about 12 cycles. Glycolysis, gluconeogenesis, glycogen synthesis, glycogen breakdown, gluconeogenesis, pentose phosphate pathway, urea cycle, purine synthesis, pyrimidine synthesis, few amino acid metabolisms. Life is miserable, right? But first time, it is like first time driving in a traffic. 2-3 times you come from Amirpet to Nampalli, it becomes routine, right? Traffic becomes routine. City life becomes routine. Now this is the urban life. What you call preparation for entrance. Medical college is rural life. You are living in a small village, like a holiday resort, beautiful life, only friends, Ghana Bajana. There is nothing to worry. Now the life is traffic, right? So don't worry. There are totally 2,000 points in entire biochemistry. 100 points 1 hour batting rate. 20 hours you give your time, I'll make you biochemistry champions. Okay. So most common enzyme deficiency is carbamyl phosphate synthase 1. 1 means there is a 2. We should know where is 2. You remember carbamyl phosphate synthase 1 is there in urea cycle. 2 is in the pyrimidine synthesis. In pyrimidine synthesis also you have a carbamyl phosphate synthase, but that is 2. How will you remember? Urea means urine, urine means 1 finger. So carbamyl phosphate synthase 1 is urea cycle. I mean, don't tell Dr. Murali teach like this, but you have to remember. And carbamyl phosphate synthase 2 is in cytosol. 1 is in mitochondria. Right? So that's what you need to remember. You can remember mummy finger 1. In childhood we used to say mom finger 1. Right? So M for mitochondria. Urea cycle. Synthase 1. Right? Pyridoxal phosphate is needed for what? Glycogenolysis. How does glycogenolysis occur? The glycogen become broken down by the glycogen phosphorylase, right? So that glycogen phosphorylase enzyme, it requires vitamin B6, pyridoxal phosphate as a prosthetic group in glycogen phosphorylase. Liver make there is a glycogen. Muscle also there is glycogen. Which glycogen contributes to blood glucose? Will both of them? No. Liver contributes. Muscle cannot contribute blood glucose. Right? Though it has glycogen inside it. Because it does not have the glycogen phosphorylase enzyme which is required to break down the glycogen is what you need to remember. Peptidyltransferase is basically a ribozyme. So ribozyme is a rRNA, ribosomal RNA, which has got a peptidyltransferase activity is called ribozyme. Now, these are all live vaccine. Yesterday only we discussed, no? Salk, K for killed vaccine, right? Then, these are all motile, but not Klebsiella. E. coli, Salmonella, Citrobacter. So once more, gram negative, gram positive. In this once more, lactose fermenters, lactose non-fermenters. There's a lot of story in microbiology. But once more, entire microbiology is not more than 2000 points to memorize. So that's the reason it required just 20 to 25 hours time. We will do that revision also. Immunoglobulins, where do you see them? You see them on the surface of B cells. So once more, what is the difference between B cell and T cell, doctor? You should know all these differences. CD3 receptor is there on T cell. Surface immunoglobulins, FC receptor, they're all there on the B cell. Surface microvilli are a feature of B cell. And thymus-specific antigen and T cell receptor is there on the T cell. So these differences you should be very, very sure about. Which immunoglobulin is produced in the secondary immune response, IgG? Acute infection, primary response, IgM. Right? Then cytomegalovirus. It is seen even in immunocompetent also. It's not that it is not. It's not that it is uncommon, right? It is a DNA virus, retinitis, and similarly, Foscarnet is the one which is used to treat the cytomegalovirus infection. Is what you need to remember. Mycobacteria, which is affecting the skin, is Merinum. Beta blockers. It is the alpha blockers that lead to postural hypotension, not beta blockers. Beta blockers lead to bradycardia. Whenever beta blocker toxicity is there, too much beta blockers are there, then on the heart, all the beta receptors are blocked. Still, you have the glucagon receptors. which can act, glucagon can act on the beta receptors which are blocked by the beta blockers. That's the reason if you want to stimulate the beta receptors which are blocked by the beta blockers, you should use glucagon to salvage beta blocker toxicity, is what you have to basically remember. Then beta blockers, some of them are lipid soluble and they can lead to the development of bad dreams, is what you need to remember. So once more, doctor, where are alpha receptors, beta receptors? This is one funda you need to know. Heart, beta 1. Only one heart, one girl in life. So beta 1. Lungs, 2 lungs are there. Remember beta 2. Beta 2 lead to stimulation of beta 2 lead to smooth muscle relaxation. That's the reason bronchodilation. All your salbutamol, salmeterol, what are they? They're all beta 2 agonistic drugs. Then you have alpha 1, which is there on the vascular smooth muscle. Alpha 1 stimulation lead to vasoconstriction, is what you need to remember. Then you have alpha 2 receptors. Where are they? Alpha 2 receptors are typically there along the presynaptic membrane at the sympathetic ganglia in the brain. So any alpha 2 stimulation decreases the sympathetic output. That's the reason alpha 2 agonistic drugs. Give an example, clonidine. Clonidine-like drugs. They're all alpha 2 agonistic in the brain. Right? One point you remember, alpha 2 is a number after 1. But 2 is presynaptic. 1 is postsynaptic on the smooth muscles. That's what you need to remember. So alpha 2 agonists are sympatholytics and antihypertensives, whereas alpha 1 agonists are vascular smooth muscle vasoconstriction, lead to hypertension. Beta 1 on the heart, tachycardia. Beta 2 on the smooth muscle, leading to relaxation and hence bronchodilation. I mean, this is the overall picture. Once more, 4,000 points are there in pharmacology. 40 hours of dedicated time. First round, first painting. Right? Then out of that 4,000, 1,500 points require second revision. 500 points require last 30 days. Bus. You will crack 10 out of 10 marks in pharmacology. जिसको फार्माकोलॉजी नहीं आता, माइक्रोबायोलॉजी नहीं आता, वो एंट्रेंस में scores will never improve. Medicine remains a big devil if you are not sure on pharmacology, right? So that is the reason we shall revise the pharmacology. But it's a very sweet subject. Pharmacology is all logic. Pharmacology is practical. Every day we use on the patients insulin, types of insulin, different anti-diabetic drugs, right? Nowadays, patients are more brilliant. They are coming with the Google, sitagliptin, do you want to give, doctor? I will give Urmila gliptin. Sita is over, Urmila time has come. So another patient will, even one of my patients, he's talking about the immunoglobulin targeted monoclonal therapy in prostate malignancy. Wow, I thought. He's a professor of English with prostatic malignancy. He knows how to read Google. So nowadays, Google, they are coming with Cochrane review recommendations of clinical practice, everything. So as doctors, we feel, oh my God, they know better than us, right? So it's good always when your patient is an educated patient, it's more easy to treat him. Glucagon is used in poisoning of beta blockers. That's what you need to remember. Carcinoma esophagus. What is a age-old chemotherapy? 5-fluorouracil cisplatin, right? Then there are various drugs, their mechanism of action. You should know what are 30S inhibitors, 50S inhibitors, all these things, mechanism of action. How does rifampicin act? How does chloramphenicol act? How does erythromycin act? All mechanism of action. There are at least 25 antibiotics and their mechanism of action. You have to be 100% sure. There are at least 30 infections and their treatment of choice. List is there. 100% sure. There are at least 80 adverse effect list. You have to know. Similarly, things like P450 inhibitors, P450 inducers, you need to know that list in the heart, by heart, and go to the exam. So don't worry. Lists are very easy to conquer, but you need to know what is the definitely commonly tested list, not all lists, right? So, doctor, chloramphenicol act on protein synthesis. Even tetracycline is on protein synthesis, not on cell wall synthesis. Metronidazole acts on DNA, penicillin on cell wall synthesis. That's what you need to basically remember. Now, overactive bladder. What is the drug which is used? Always remember, doctor, bladder is a beautiful topic. The bladder has a detrusor muscle. This detrusor muscle is supplied by parasympathetic innervation. Parasympathetic stimulates the detrusor and causes the urine to pass out. Right? On the other hand, you have the sphincter. So sphincter is basically supplied by sympathetic. Right? So now this parasympathetic is a stimulant of the detrusor. So that is the reason if the bladder is overactive, for example, somebody has a cystitis, then bladder becomes irritable, overactive. You need to relax it. For that, what you should use? Anticholinergic. Somebody has a retained urine inside a atonic bladder. To increase the tone, you have to give cholinomimetic, right? Always anticholinergic, what will they do? Anticholinergic will cause salivation. Anticholinergic will cause drying of the mouth. So anticholinergic is used to treat the overactive bladder, and that lead to development of anticholinergic effect of xerostomia. See what's happening in organophosphor poisoning, doctor. Organophosphor is a acetylcholine esterase inhibitor. If acetylcholine esterase is not there, acetylcholine is not broken down. So increased acetylcholine will be there, and that lead to cholinomimetic effect. That's the reason we give atropine as a treatment of OP poisoning to antagonize the cholinergic effect. Excess acetylcholine, what will it do? Patient will be salivating and bladder is compressed and he passes the urine into his lungi when a patient is being brought, right, with OP poisoning, right, into his dress. So cholinomimetic will make us to secrete. Anticholinergic will make us dry. That's a simple principle. So which is that drug which is anticholinergic? Oxybutynin is considered to be anticholinergic. So xerostomia, difficulty in urination, constipation, all these anticholinergic effects similar to atropine will be there if you try to use that drugs for overactive bladder. Which drug is used in narcoanalysis? You give the drug and make the person speak the truth. Scopolamine. Scopolamine is also used for motion sickness. Osteoblastic secondaries are predominantly seen in prostate cancer. Right? So, which primaries lead to lytic lesion predominantly? Renal cell carcinoma, lung carcinoma, GIT carcinoma, malignant melanoma, right? Malignant melanoma. Then which secondaries lead to osteoblastic predominantly? Carcinoma colon, carcinoma breast, prostate adenocarcinoma. So these are the list you have to remember and memorize. Which lung cancer commonly lead to paraneoplastic syndrome, doctor? Small cell carcinoma. Once more, bronchogenic carcinoma, there are at least 20 points to remember. Like, which variety of the lung cancer quickly spreads with metastasis? Quickly spreads with metastasis. छोटू भागता है, छोटू भागेगा. The small guy will run fast. Small cell carcinoma, metastasis, very fast. By the time of your diagnosis only, you will find adrenal mets. That is the reason. Second question. There is no role for surgery in which lung cancer? Small cell. Because already it metastasized, you have to cut the whole body. If you have to cut out small cell cancer. What are the two lung cancers which are central in location? That is, they are perihilar, not peripheral. Remember, SSC. Secondary school certificate, I passed SSC, we say no. Small cell, squamous cell. They are central. Adenocarcinoma is peripheral. Like this, there are at least 20 points on lung cancer. If before entrance, if we scratch also, you should tell all the 20. Right? So, entrance preparation, does it require brains? No brains, only spinal cord. Fevicol, you require a good Fevicol. Put it on the table, sit on the Fevicol, जोर से लगाओ, निकलोगे नहीं. Right? So that is the willpower. It's more a test of willpower than anything else, doctor. Be very, very sure about. Now, these are all infections transmitted through blood transfusion. Hepatitis G, CMV, dengue, but not Q fever. Q fever is by droplets. Now, Down syndrome, neurofibromatosis type 1, and chromosome 13 deletion, they all lead to malignancy. Chromosome 13 deletion is responsible for retinoblastoma and osteosarcoma. You know very well, RB gene, retinoblastoma gene, is on chromosome number 13. How will you remember? 13 is called teenage. From teenage, our eyes start looking differently at the boys and girls, right? So you can remember I-13 is the retinoblastoma gene. Paraneoplastic syndrome, in which antibodies are absent, is which one? It is the necrotizing myelopathy. So you should know what are the neurological paraneoplastic syndromes. Generally, all these what is a paraneoplastic syndrome? A tumor did not spread to the organ, but from distance it is causing a effect by causing production of some antibodies sometimes. So if you take stiff person syndrome, limbic encephalitis, or cerebellar degeneration, right? They're all associated with antibodies, like anti-Hu, various antibodies are there, right? The only thing is necrotizing myelopathy is without antibodies, it leads to paraneoplastic syndrome is what you need to remember. So anti-O, anti-TR is associated with cerebellar degeneration. Anti-Hu, anti-Ta lead to limbic encephalitis. Then patients who have the small cell lung cancer, ovarian, breast or uterine cancer, present with dysarthria, ataxia, nystagmus. So a lot of times oncologists, neurologists, immunologists, they all work together. Ultimately, they can't do anything for the patient. They make a good diagnosis. Wow, I diagnosed it. I diagnosed it, they will say. Immunologists are happy. They earn money also in diagnosing. But where is the treatment? Right? So that's a pathetic thing. Apoptosis. Let me tell you, doctor, once more. Without a question on apoptosis, there is no entrance exam till now conducted. Right? Show me one question paper without a question on apoptosis. I'll resign from teaching. Right? So tomorrow's NEETPG also, May 21st, you will get apoptosis question. You will remember me in exam hall. Right? So apoptosis is a non-inflammatory shedding of the cells. So there's a programmed cell death, cell shrinkage, phagocytosis of the breakdown products. Hepatosomes are formed because of that, no inflammation. Florence test is for, typically it detects the choline in the semen. So you should know all the seminal stain tests. Florence, Barberio, acid phosphatase, blah, 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 everything. I leave the literature for you. How long you need to maintain the medical records of the patients? There is a legal obligation for 3 years. Formaldehyde injected for embalming is 40% in concentration. Until when you can say, my husband killed me for dowry, up to 7 years. Beyond it, you killed yourself. Then after that, blood usually remains fluid, except if there is a pneumonia, then the blood will not be fluid. Human Development Index, adult literacy, per capita income, and life expectancy. Infant mortality rate is not included. Infant mortality is included in PQLI, right? Already in SPM, first 1,000 points are over. Please take a chance to review it. We left it on the YouTube, right? So what is the measure of infectivity? Secondary attack rate is the measure of infectivity. Iodine in iodized salt, Tata salt, is how much? 15 ppm. Case control study, we use odds ratio, AD by BC, odds ratio. So once more, what is odds ratio? What is relative risk? What is attributable risk? All this funda is over. We discussed, debated, and made it available in the YouTube. How much residual chlorine should be there for 1 hour contact period? 0.5 is a numeric. In PQLI, you have literacy, life expectancy at age 1, and the infant mortality. Ultra low volume fogging, we use malathion. Sampling in a non-homogeneous group. Suppose a group has different age structures. 80-year-olds, 70-year-olds, 60, 50, 40. Non-homogeneous group, not all 80. So there you need to stratify them and then do random sampling. That's called stratified random sampling, need to be done whenever the group is non-homogeneous, is what you need to remember. Under ESI, sickness benefit for confinement is how much? 30 days. So you should be very sure. Confinement, miscarriage, sickness arising out of confinement is 30 days. Confinement is 12 weeks. Miscarriage is 6 weeks. That's what an employer must provide a sickness benefit. Under RNTCP case detection. This is a little old question. These statistics completely changed. So I will give you, at least there are 100 statistical values. Like what is the annual infection rate of TB? Then a lot of new schemes are coming up nowadays. It's completely now a new story has come. I'll even the category 1, category 2, and all that is being changed. So we will discuss all the recent recommendations. Cyclopropagative means what? Both multiplication and development occur in cyclopropagative. Agent undergoes both development and multiplication in the transmitting vehicle. Developmental means agent undergoes some development in the vector. Propagative means agent only multiplies, no development from one stage to other stage. So plague bacilli in rat fleas is propagative. Guinea worm in cyclops and filarial parasite in culex are developmental. And plasmodium and trypanosome in mosquito and CC fly is cyclopropagative. Some way you need to remember these 3 points. Last 30 days revision में डाल दो 3 पॉइंट को, क्योंकि भूल जाते, अभी से याद रखे तो जरूर भूल जाते, बट किस पॉइंट्स को नहीं भूलना लास्ट मिनट में, that collection must be ready. You are still studying in the last 30 days means you are not ready for the exam. Last 30 days is just a nostalgic memory. Once more, this happy, fine time of preparation. You know, one of my friends used to say, this part of my life is sponsored by my father-in-law. He used to put a board outside while we were all preparing. This part of my life is sponsored by my father-in-law. Don't disturb. And don't ask me, how is your preparation? Why should I tell you? He used to say. What we did was, we prepared well, not even qualified in the entrance. Then still people are asking, क्यों भाई क्या चल रहा है जिंदगी, कैसे चल रहा है, what is next, what is next? So we thought, once more, if we say next entrance exam, these fellows will kill us. We are all planning to go for USMLE. Indian entrances are not meant for us. Finish. They won't ask any question. Right? Because there is no notification for USMLE. There is no counseling for USMLE. So this, and it's a high status symbol in reading room. Oh, these guys are going to America. Shortly we are going to see in Harvard, Stanford or something. But we are actually preparing for JIPPER, PIPPER and all these exams. So how do we manage expectation of others in life is the big challenge. So what are the most cost-effective intervention for non-communicable diseases like hypertension, diabetes, everything? Primary prevention. So when you have finished your MD general medicine, you will be like this. You are sitting in the OP and telling people don't eat, don't maintain exercise, please take the tablets on time. 8 to 10 hours you are sitting in the same OP room, and one day you will realize that you are like this, right? So during entrance preparation also, make sure that you play some table tennis or some sport, volleyball or football or some sport. Otherwise, one of the risk factors for NCD, non-communicable diseases, is NEETPG preparation. Continuously sitting and bothering about, will I get seat or will I not get seated? So you will automatically get seat. Now, a beta lipoproteinemia. Why there is a delayed clotting? Basically, in a beta lipoproteinemia people, there is a fat malabsorption. And fat soluble vitamin is vitamin K. That's the reason it leads to vitamin K deficiency. That leads to development of coagulopathy in beta lipoproteinemia patients. Once more, doctor. Familial lipoproteinemias. Dirty list is there. There are about 7 conditions and there are 3 to 4 points about each of them. Totally a bundle of 25 points. We need to put it in pocket and go to exam. There is no entrance exam without a question on lipoproteins, hypolipidemic drugs. And practically also everyday life we give statins, we use gemfibrozil and all these things, right, doctor? So that's the reason you need to remember a beta lipoproteinemia. Now, what is the criteria for a transudate pleural effusion? So you should remember exudate versus transudate. Transudate has WBC more than 1500, protein 3.5, specific gravity 1.020, and RBC less than 5000. So when you take pleural effusion, what is that criteria called? Light's criteria for pleural effusion. You need to be very, very sure about. So what is the inheritance of familial hypercholesterolemia? So once more, our dirty list has come. So this list I keep on asking you every Sunday, right? At least you should tell after 5-6 Sundays, I know, sir, everything about it, right? So type 1, type 2, type 3, what is the defect, which lipoprotein is increased, what are the symptoms, what is the treatment, how is the appearance of serum, everything you should know. I leave the literature for you, right? So please do take an opportunity to review. Kawasaki. Kawasaki is what, doctor? Vasculitis. Vasculitis are divided into large vessel, small vessel, medium vessel, right? Medium sized vessel. What are large vessel vasculitis? Giant cell arthritis and Takayasu arthritis. Takayasu arthritis involves arch of aorta. Aortitis, right? Arch of aorta will show inflammation. The cletus subclavian, which is originating from aorta, become narrowed. That's the reason you don't find pulse. It's also called pulseless disease, is the name given for Takayasu arthritis. Then you have small vessel vasculitis, like your Wegener, Henoch-Conlin purpura, etc., etc. Then medium sized is the Kawasaki. Kawasaki is a bike. It is not a lorry. It is not a bicycle. It is a medium vessel. So that way you can remember Kawasaki is medium vessel. There are around 50 points in the entire topic of vasculitis, doctor. 50 points. Cryoglobulinemia, Henoch-Conlin purpura. Totally around 11 to 12 conditions are there. Each vasculitis, 4-5 critical points you need to remember. And once you do that, first time, wow. Second time, you're ready. Okay. So in Kawasaki, pedal edema, strawberry tongue, thrombocytosis, they're all the features. But it is a non-exudative conjunctivitis. Non-exudative conjunctivitis, not a exudative conjunctivitis. And Kawasaki, what is the main problem? Why the two things? Kawasaki occur in pediatric population, in children, and Kawasaki lead to coronary vasculitis. So heart attack in a newborn baby, in a small baby, is due to coronary vasculitis caused by Kawasaki. Okay, so we will discuss all that separately. And also, Kawasaki is also called mucocutaneous lymphadenitis is the name. So there are mucosal lesions like non-exudative conjunctivitis, cutaneous lesions, and also lymphadenitis is also the feature, is what you need to remember. So that is the story, doctor. Very good. Am I going too fast? Sunday grand test means we have to be really fast. That's the reason you come at 9 o'clock and take 3 hours solid time to guess. Right or wrong, you answer all 200 questions. Make it a habit. Then after during discussion, you do correction. You change the question papers and do correction. Right? Then you will know what is your score, how good you are doing. And after going home, eat a nice biryani, sleep, get up, have a cup of tea, and then sit. Chalo bhai, aaj my 200 marks mein vasculitis completely clean board, ECG completely clean board, hyperkalemia completely clean board. You pick up 10 topics and do revision of 10 topics and be very sure that once more in these topics I should not go wrong. That way every week you are improving 10 topics. Automatically by the time it is October, November, you will become talwar ke tar ke jaise, chamakte sitar ke jaise. You will get ready for attacking the examiner. Right, doctor? So gold standard test for diagnosing gastroesophageal reflux is ambulatory pH monitoring. Now, with regard to the heparin can cause two types of complications. Heparin-induced thrombocytopenia, in that you have type 1 and type 2. So you should know why type 1 occur, why type 2 occur, where you need to stop giving heparin, and how do you treat heparin-induced thrombocytopenia. All those things you need to understand, right? Heparin does not dissolve clot. It is not streptokinase or urokinase to do that. Heparin prevents new thrombus from forming because it is antithrombin, is what you need to remember. So, heparin-induced thrombocytopenia, at least 5-6 points I will tell you. Typically less than 1 lakh will be platelet count. 5 to 10 days after heparin. And low molecular weight heparin has less risk. And females more than males. Similarly, malignant patients, post-surgical patients, surgery patients also, to prevent DVT, you will give heparin. They are also at risk. And one peculiar thing, heparin is antithrombotic. Heparin lead to HIT. HIT means thrombocytopenia, but the tendency will be thrombotic tendency. Because though the platelet count is low, those platelets have a sticky tendency. So that lead to thrombosis, right? So that is a story about HIT. And it is the antibody against heparin PF4 complex. That is the main reason. And how do you treat the thrombosis associated with HIT? You have given heparin to prevent thrombosis, but heparin led to HIT. HIT led to thrombosis. Then how do you treat that thrombosis? You have to give direct thrombin inhibitors. What is meant by heparin? Heparin is called indirect thrombin inhibitor. Why? Because it will go and make antithrombin get activated. And antithrombin typically will lead to prevention of thrombus. Not directly heparin will come and do something. So the thrombosis related to the heparin-induced thrombocytopenia is treated with direct thrombin inhibitor like lepirudin, argatroban, bivalirudin, fundaparinox is what you need to remember. There is hypertension, alkalosis, hypokalemia. Where do you see this combination? Always remember, doctor, high renin lead to high aldosterone, lead to sodium retention, potassium loss, and H plus loss. This lead to alkalosis. This lead to hypokalemia, and this lead to hypertension. Renin-angiotensin aldosterone system lead to hypertension. So where do you see that? We see that in Cushing's syndrome, Conn's. What is Conn's syndrome? Primary hyperaldosteronism is called Conn's. Right? So whenever adrenal has a tumor, then it produces excess aldosterone, and that suppresses the renin. So high aldosterone with a low renin indicates it is primary hyperaldosteronism, Conn's syndrome. Whereas secondary hyperaldosteronism, where do you find? Whenever you are dehydrated, dehydration decreases plasma volume. Plasma volume decreases renal blood flow. Renal blood flow stimulates renin. High renin lead to high aldosterone. So in dehydrated people, high renin, high aldosteronism is called secondary hyperaldosteronism. Whereas in adrenal adenoma patients, low renin, high aldosterone. Because adrenal adenoma don't require renin to produce aldosterone. Without telling of renin only, it will produce aldosterone. And that high aldosterone will suppress renin production. So low renin, high aldosterone is primary hyperaldosteronism due to adrenal adenoma. High renin, high aldosterone is because of secondary hyperaldosteronism because of the dehydration of a person, which can be due to your diuretics or anything. All right, doctor. Huh? Totally, endocrinology has pituitary, thyroid, adrenals, Cushing's. Not more than about, there are about some 15 to 20 conditions. So 700-800 essential points. Out of them, 300-400 analytical points will be there. High renin, high aldosteronism is equal to secondary. Low renin, high aldosterone is equal to primary hyperaldosteronism. All that logical points will be there, no? They'll be very high. In endocrinology is the only logical subject in the entire medicine. Right? Congenital adrenal hyperplasia. What happens in 21 alpha hydroxylase, 11 alpha hydroxylase, 17 alpha hydroxylase? Each of these enzyme deficiencies, which will lead to excess aldosterone, low aldosterone, which lead to excess sex steroids, low sex steroids. All these things. Anybody? Dali. So remember, doctor, there is one Liddle syndrome, Gitelman syndrome, Bartter syndrome. If I discuss this, I won't get time to finish 200 questions, but still I will quickly add. Remember, Bartter syndrome is like taking Lasix, furosemide. How does loop diuretics act? They act on the ascending limb of loop of Henle, right? So there is a sodium potassium 2 chloride transporter. So they block sodium potassium 2 chloride transporter in the loop of Henle. Just like furosemide, if you give, in these people, congenitally only, the sodium potassium 2 chloride co-transporter is defective. Because of that, just like if you give furosemide, what will happen? You lose sodium into the urine. Right? So Bartter is like Lasix. Gitelman is like thiazide. Where does thiazides act? They act on the distal convoluted tubule. Right? So, one simple way to remember. Loop diuretics lose calcium. Thiazides retain calcium. So who is like thiazide diuretic? Gitelman. Gitelman is like thiazide. And Bartter is like loop. How will you remember? Gentleman is what? Jittle. Jittle is Zad. Thiazide is Zad. So gentleman is Zad. So he's like, now obviously barter is like loop directing. So barter patients lose calcium into urine like people on Lasix, furosemide. And gentlemen retain calcium and they present with excess calcium. Then Liddle's is like hyperaldosteronism. So what is the problem in Liddle? Where does aldosterone act? You have glomerulus, descending limb, ascending limb and collecting duct, right? Here you have the sodium transporter. So you have the receptors. When aldosterone act on them, they will open and sodium will be retained into the body. What happens in Liddle's? In Liddle's, there is a mutation of these sodium channels. And even without aldosterone only, they remain permanently opened. That causes sodium to become continuously reabsorbed and potassium and H plus to continuously lost into urine. So that is the reason Liddle's is like Conn syndrome, like hyperaldosteronism condition. Understand? So that is what you need to remember. That's the reason, just like in Conn syndrome, what do you have? In hyperaldosteronism, you have hypertension, hypokalemia, and metabolic alkalosis. Why? In Conn syndrome, because the high aldosterone is causing sodium retention, potassium loss into urine, H plus loss into urine. Loss of H plus lead to loss of acid and metabolic alkalosis. So hypertension, metabolic alkalosis, hypokalemia, this combination is what you see in Conn syndrome because of hyperaldosteronism. The same thing is seen in the case of Liddle syndrome, but in Liddle syndrome, it is not excess aldosterone. Without aldosterone only, the sodium channel is continuously in the opened state. Don't worry, relax. Once more, we will discuss all this story. So one of the favorite questions of the exam, how do you differentiate Conn syndrome from Liddle syndrome? Look for aldosterone. Conn syndrome has high aldosterone, but Liddle syndrome has a suppressed aldosterone. Even though aldosterone is low, it behaves like hyperaldosteronism because of the defective sodium channel is what you need to remember. That's all the story. Still, we are not fully done, but a small introduction to you that there is a devil called Barter, Liddle, Gentleman, which is going to Conn syndrome, which is going to come for our discussion in the next assembly meeting. Now, proximal myopathy. Always remember, doctor, simple rule. You have neuropathies, you have myopathies. If you don't know either of them, after writing NEETPG, you have to go to Tirupati. If you don't know neuropathy, myopathy, and go to NEETPG, then you have to go to Tirupati. Right? So, remember, whenever Naru pathology is there, the weakness of the muscle is distal. Distal means your fingers and toes. Whenever myopathy is causing weakness, muscle problem, then the weakness is proximal. There are exceptions in both of them, which is the myopathy, which causes distal muscle weakness, which is the neuropathy instead of causing distal, which causes proximal muscle weakness. We will discuss later. But for now, what will you remember? Myopathy's weakness is always proximal muscles, neuropathy's weakness is always distal. That's what you need to remember, right? So, Duchenne's muscular dystrophy, Becker's muscular dystrophy, polymyositis, they're all what? Proximal myopathies. So, the myotonic dystrophy is a myopathy. It is not proximal, it is distal. Okay, that is the exception. All right? So, Xanthochromia, that yellow tinge in CSF, where do you see? Whenever there is subarachnoid hemorrhage, increased proteins, jaundice. Similarly, if you are doing any spinal lumbar puncture, then spinal subarachnoid block lead to what is called Freund syndrome. There also you find xanthochromia of the CSF is what you need to remember. You want to know how good is myocardium after heart attack. How can you know that? For that we use the PET FDG. PET scan is the one which is basically used, where you'll be using fluorodeoxyglucose to assess the myocardial viability. Giant A wave. So why does A wave occur, doctor? Atrial contraction in the last 1/3 of the diastole will cause the increased pressure inside the jugular vein, which is called A wave. So giant A wave is there means when last 1/3 of the ventricular diastole, if the atrium is contracting against a stenotic valve, right? Of course, on the right side, stenotic valve, tricuspid stenosis, or complete heart block, or pulmonary hypertension. In all these scenarios, what will happen? The atrium is contracting against a closed or a stenotic valve. That causes more pressure to rise in the jugular vein. That leads to development of giant A wave is what you need to basically remember. Homonymous diplopia, heteronymous diplopia. First of all, what is diplopia? Two images. Two images. So, isotropia lead to homonymous diplopia. Exotropia lead to heteronymous diplopia. 1 to 2 words about it. So, homonymous diplopia. The image received by the right eye is on the right side. Image received by the left eye is on the left side. And the false image is on the outer aspect of the true image. That is the nature of homonymous diplopia. And when does it happen? Whenever you have a convergent squint, right? You get homonymous diplopia. 3 points about it. Homonymous diplopia is seen in convergent squint. The right eye image is on the right side, left eye image on the left side. And the false image is outer aspect of the true image. 3 points. Then what do you see in heteronymous diplopia? Suppose your oculomotor is paralyzed. Then abducens, unopposed pulling out is happening. Then your eyes are going into exotropia. Then you get heteronymous diplopia. That means right eye's image will be seen on the left side, left eye image is seen on the right eye, typically. So that is called heteronymous diplopia of exotropia. Right? That's what you need to remember. So I leave the literature. There is an excellent teacher called Dr. Mehboob, who is from All India Institute of Medical Sciences, Delhi, and he will be teaching ophthalmology revision. Okay, so you will really enjoy the session. Even in ophthalmology, 2,000-3,000 points is all that you need to master, right? Then Waldenstrom's macroglobulinemia. What do you see in Waldenstrom's macroglobulinemia? Lymphoplasmacytic lymphomas are associated with Waldenstrom's macroglobulinemia that produce IgM. Once more, multiple myeloma is a hot topic for entrance. Without that, there is no paper. Right? Erosion of the bones is seen in, always remember, SLE lead to non-erosive arthritis. If erosions are there, it is not SLE. So non-erosive arthritis, if you happen to take X-ray of SLE arthritis patient, no erosions. Erosions are a feature of rheumatoid arthritis, gouty arthritis, psoriatic arthritis, right? Once more, in rheumatology, there are at least 8 to 10 types of arthritis. Seronegative arthritis, seropositive arthritis like rheumatoid arthritis, right? So you should know differentiation of the two, right? We will discuss that. Rasmussen's aneurysm, where do you see? Typically pulmonary artery. So it can lead to hemoptysis, which can be life-threatening. So whenever there is a tuberculous cavity, inside the cavity there is an aneurysm of the pulmonary artery, which is called Rasmussen's aneurysm, which can undergo the bleeding. Now there's a road traffic accident. Following that, patient became dyspneic and petechial hemorrhages on the front of the chest. Even closing the eyes, you can tell it is a pulmonary. It is a typical air embolism, which occur with long bone fractures. Is the classical feature. What do you see in Cushing's disease? Cushing's disease is because of the problem in the pituitary, right? Pituitary's tumor or something is overproducing ACTH, and that is causing, in turn, increased cortisol, right? So you should know that Cushing syndrome, what is the syndrome? Cushing syndrome, any hypercortisolism is called Cushing syndrome. That hypercortisolism can be produced by problem in pituitary, problem in adrenal, right? Or ectopic ACTH production, any of them. Then when do you call Cushing's disease? If this Cushing syndrome, which is hypercortisolism, is because of pituitary adenoma hyperproducing ACTH, then you call Cushing's syndrome. And nowadays they removed all this terminology, Bharadwaz terminology. In our days, Bharadwaz professor used to say, ha ha ha, do you know what is Cushing's syndrome and what is Cushing's disease? So we prepared a list. What are the favorite Bharadwaz questions of the professor? Because they're all very limited. Because professors don't read. They keep repeatedly asking same questions. So we gave to the juniors. Because they're fresh from entrance exam, right? Toppers. So it doesn't take, hardly there will be about 50, 60 FAQs asked. The moment the professor opens mouth, before asking question only, they used to tell answers. What is this? Where is it happening? Because the entrance guru, Dr. Murali Bharadwaz, is in the second year of MD, we used to say. Right? Because we know how to tune. First year, हमको पूरा दिमाग खराब कर दिया आपने questions पूछ के. Very standard questions they used to be. Similarly, there will be some triggers, irritable triggers in the ward rounds. You know who is a good PG, bad PG? Good PG is the person who knows every bed ka laboratory values in tips. The one who collects reports. One who does rounds before chief. Chief should not know more than you about the patient. If he knows more than you, you are a bad PG. Right? So, but we used to have so many cases in the night duty. We used to tell, if the patient's name is Abdullah Asghar Ali, 5 to 6 children, we used to tell family history. Because Asghar Ali saab tak minimum 5 to 6 children to produce karega, right? So that's what we end up in. Yeah. So you know, Cushing's disease is pituitary adenoma. Cushing's syndrome is anything leading to hypercortisolism. Now regarding Crohn's disease, you need to know Crohn's can cause is a risk for cancer. It can lead to infertility. We use TNF-alpha inhibitors in the treatment, right? ANCA positivity is a feature of not Crohn's, right? So regarding ARDS, typically ARDS causes what type of respiratory failure, doctor? Type 1 respiratory failure. Once more, what is type 1, type 2 respiratory failure? Both type 1, type 2. Simple thing you remember. Once more, I may not get time. Both will lead to hypoxia, doctor. But type 1 PCO2 is normal. Type 2 PCO2 is increased. That's the only difference. Type 1 and type. Both will lead to hypoxia. So you have the trachea, bronchi, bronchioles, alveoli, right? So then you have the vascular capillaries, where the exchange, alveolo-capillary bed exchange is happening. Any pathology at this level between alveoli and capillaries will not let oxygen to diffuse, but still CO2 can diffuse. That is the reason any pathology at the alveolo-capillary membrane lead to type 1 respiratory failure with hypoxia with normal PCO2. What is type 2? You take the person and hang him. Then where are you causing obstruction? Trachea level, main bronchi level. Neither CO2 can go out nor oxygen can come inside. So that is type 2. If I drown in water, what type of respiratory failure? All the water will enter and then there's a pulmonary edema, alveolar capillary level, type 1. If you hang me, like Saddam Hussein, type 2. Simple. Only type 2 PCO2 rises. You are hanging, no. PCO2 rises. Person also rises to heaven. Simple thing you remember, right? So, ARDS is alveolar edema. What type of alveolar edema is ARDS? Non-cardiogenic pulmonary edema is acute respiratory distress syndrome. Even when heart fails, cardiogenic also can cause pulmonary edema. So what is the difference between ARDS and this? Non-cardiogenic pulmonary edema is ARDS. Cardiogenic pulmonary edema is what you see in CHF, left ventricular failure. So that is the reason take the X-ray in a patient of pulmonary edema. Look at the heart size. If the heart size is normal, then it is ARDS. If the heart size is enlarged, then it is left ventricular failure, cardiogenic pulmonary edema. All right? Are you done? Still have energy? In cricket, they say, no, once they hit 100, they will raise the bat. See, we are still in the first Sunday grand test for you guys. We'll hit 100 and call it a day. All right? Are you waiting for 200? Huh? You have energy for, how many don't have energy for 200 can raise the hand honestly? I know that. How about you? Energy, you know that? 200K? Okay. In that case, we will take a break and then restart something. First, let me quickly touch 100 and then we'll take a break. Thalamic bleed. What does it lead to? Thalamic bleed. Typically, it leads to the gauge palsy. Thalamic bleed. Right? So, whenever thalamus, okay, what is thalamus? You know hypothalamus. What is thalamus? Remember one simple thing. All sensory information. A boyfriend touched your hand, right? Somebody kissed on your cheek. Wow, great feeling. All the sensory information will pass through thalamus. That's the reason in Greek, thalamus means bedroom. So all pleasures of life are in bedroom. So thalamus, according to Greeks, is bedroom. All sensory information need to pass through thalamus. So you have the brainstem. What is brainstem? Midbrain, pons, medulla, then spinal cord. Above that you have the thalamus. Above that you have the cerebral cortex. In that you have sensory and motor cortex. So all sensory information passing through the brainstem reaches the thalamus. From here it will go to sensory cortex. Rule number 1. समझ में आ गया? All motor output coming from the brain. It has to pass through. What is the center for motor activity consolidation? Huh? Pons. Pons is the place all motor activity has to pass through the pons. That's the reason whenever there is any pontine hemorrhage or pontine myelinolysis, it's called central pontine myelinolysis. If you aggressively treat hyponatremia, the myelin will be lost from the pons. Pons will lose all activity. All motor output passing through the pons will get blocked. You can't raise upper limbs nor lower limbs. You will be lying down like a frog. Only motor activity left in you is you can do the up and down gazing of your eyes. Because that gazing of up and down of your eyes center is located in midbrain, which is above pons. Otherwise, all the motor activity is gone. And that kind of a frog-like condition is what you go into whenever there is a central pontine myelinolysis and pons is affected. So quickly summarize, doctor. Center for efferentiation is thalamus. All right? No worries. So I leave all the literature for you. How will putamen lesions look like? How does pontine lesions look like? How does thalamic lesions look like? ACA, MCA, PCA. All these three territory strokes. How will be the clinical presentation? Simple. Then there are 5 to 6 brainstem. Weber syndrome, Clot syndrome, Benedict syndrome. All those things we will discuss. Tumor lysis syndrome. So typically what will happen in tumor lysis syndrome? Every time tumor cell is broken down. So what is the classical type of leukemia where you get tumor lysis syndrome after you start chemotherapy? APML, acute promyelocytic leukemia, which is the M3 variety of leukemia. In this, very often when you start chemotherapy, you get tumor lysis. So even lymphomas, also tumor lysis syndrome once you start chemotherapy. So what is the electrolyte which is inside intracellular ions are what? Which one? Potassium is intracellular. So that get released, right? And calcium is intracellular. That also get released. So you get hyperkalemia. Sorry, not calcium. Phosphate is inside the cell. It get released. So you get hyperphosphatemia, hyperkalemia. All that phosphate release will sequester the calcium. So you get hypocalcemia, hyperphosphatemia, hyperkalemia whenever tumor lysis syndrome is there. So hyperuricemia, hyperkalemia, hypocalcemia, hyperphosphatemia, acidosis, and acute renal failure. That's what you see with tumor lysis syndrome. Retrocardiac air-filled shadow. This is the retrocardiac air-filled shadow. You are able to see the air-filled shadow here? Where do you see? Whenever there is any sliding hiatus hernia, where the gut is herniating. In TPN, what do you get? Total parenteral nutrition. Hyperglycemia, hypernatremia, hypocalcemia, hypochloremic metabolic alkalosis, metabolic acidosis, hyperaminoacidemia. These are all the problems of TPN. Blue lines on the gums with the tremors, lead poisoning. That's called Burton sign, blue line. You can go back to the Google images and check for Burton sign. Acute alcohol consumption, what will it lead to? Lactic acidosis. So why lactic acidosis? Alcohol is ethanol. Ethanol is oxidized to acetaldehyde. Acetaldehyde, when it gets oxidized, NAD becomes reduced to NADH. And a high NADH will increase the lactate levels. It impairs gluconeogenesis. That's the reason alcoholics will get hypoglycemia very fast. Glucose levels will fall down. Second, their lactate levels increase. Understand? So that is what you need to remember. Lactic acidosis, hypoglycemia, inhibition of gluconeogenesis because of the high NADH. NAD become converted to NADH. You know, in glycolysis, what will happen? Glucose to glucose 6-phosphate to glucose 1,6-diphosphate to diacylglyceride, right? So ultimately, it will come and become pyruvate. Pyruvate can become acetyl-CoA in enteric acid cycle, or pyruvate can become lactate. So will pyruvate become lactate or go into citric acid cycle is decided by whom? It is the NADH levels that will decide. If you have low NADH, then pyruvate is tempted to go into citric acid cycle by becoming acetyl-CoA, because citric acid cycle produces NADH. But already NADH, if it is high, then pyruvate is pushed to become lactate. That is the reason lactate levels increase, because the high NADH. From where is this NADH produced? All your ethanol is oxidized into acetaldehyde. In the process, NAD become NADH. Right, doctor? Restrictive lung disease, obstructive lung disease. How do you differentiate? Increased FeV1 by FVC with a decreased compliance of lungs, stiff lungs in restrictive lung disease. FeV1 by FVC become increased. That's what you need to remember. In Graves' disease, cardiac failure occurs, but it is rare. It's a rare complication, only 6% of cases. All the remaining are true statements. Exercise ECG, treadmill test. What are the contraindications? If the patient has unstable angina, you push him on stress ECG, you are finishing the unfinished job of God by being a cardiologist. So you should know list of absolute contraindications. In amyloidosis, there is a renal deposition leading to renal failure. What is the common cause of death in amyloidosis? Infections and renal failure. Amyloidosis can cause restrictive cardiomyopathy. Amyloidosis abdominal fat biopsy is diagnostic. In multiple myeloma, there are lytic bone lesions, right? How do you recognize multiple myeloma? Simple. Is there any simple laboratory test that will strike your mind that it is multiple myeloma? LFT. You have, what do you see in LFT? Total serum protein, which is typically how much? Around 6. Albumin is typically how much? Around 3 to 3.5. But suddenly patient came to you, right? And he has 10 total serum protein instead of 6. And albumin is same, 3 only. That means what is filling between the 10 and 3? Globulins. And multiple myeloma is monoclonal hypergamma-globulinemia. Right? So, looking at LFT, this is called reversal of albumin-globulin ratio. Normally, albumin will be higher than globulin. But if globulin is higher than albumin, that's called reversal of albumin-globulin ratio is one clue. An elderly person came with body pains, severe body pains, bone pain, with lytic lesions, with anemia, with a high ESR. Suddenly your friend called and said, hey, you sent me complete blood picture. There's a lot of Ruli formation, Rulex formation. That is another clue. Immediately you should run and look for LFT. In LFT, albumin globulin reversal is there. And your friend is pathologist telling that there is a Rulex formation. And the patient is elderly sitting there with anemia, with body pains, bony pains. And immediately look at the X-ray, you found the erosive lesions. Finished, diagnosed, done. And how to diagnose? Send bone marrow biopsy. Bone marrow biopsy, their plasma cells in the bone marrow. More than 30% plasma cells is the definition of multiple myeloma. So plasma cells produce immunoglobulins, lymphocytes and immunoglobulins, right? So multiple myeloma is what? Plasma cytosis with monoclonal gamma globulin production, right, doctor? Huh. We'll take a quick break, 5 minutes, and then we'll restart. Okay, doctor? Everything is stamina, doctor. We give up, we are gone. We want to persist, we stretch ourselves more, our stamina improve. Entrance is a test of stamina. At this June 6th, I will be entering 50. So at 50, if I have stamina, you should have stamina at 24, 25, right? You're half my age. ఏం రఘు టీ బ్రేక్ అంటే టీకి తాగిపియాలి నువ్వు నెక్స్ట్ సండే నుంచి ఏంలే ఒక మిల్క్ ప్యాకెట్ తెప్పియండి, ఒక చిన్న స్టవ్ అరేంజ్ చేద్దాం. చాయ్ బనా తెప్పియండి. Once upon a time, we used to have all that kitchen is there, no? In that, we'll put one gas stove and then get some nice Charminar biscuits. So, anybody who want to have tea can prepare their own tea and drink. Yeah, that tea will be much better than the coffee machine tea, right? Whenever I come, I'll get nice South Indian filtered coffee decoction, right? Yeah. So welcome back and coming to our journey. A 4-year-old with bronchial asthma with 3 and more episodes during daytime and 2 wheezing episodes during nighttime. How will you grade? This is another disgusting thing to remember. When do you call severe persistent, moderate persistent, mild persistent, mild intermittent? This is how the asthma is being graded. It depends on whether daytime symptoms, nighttime symptoms, how is the FEV1 and how is the variability of the peak expiratory flow. I leave the literature for you. I won't read it for you, right? But you need to read, remember, reproduce in the exam. Hutchison's triad. Chedu vinavaddu, chedu chudavaddu, chedu matladavaddu. 3 monkeys of Gandhiji. So don't see bad. Interstitial keratitis. Don't listen bad. Sensory neural deafness. And don't speak and open mouth. Notched incisors. Low birth weight means less than 2.5 kg. Very low birth weight means less than 1.5 kg. Then nocturnal enuresis, bedwetting is abnormal after 5 years. How much protein in 100 ml of breast milk? The mom's milk is for the baby, cow's milk is for the cow's baby, right? So that's the reason you should be very sure how much cows, buffalo, goat, except pig, everything else you need to remember. This is called entrance hai, NEETPG hai. So 1.1 gram is what you need to remember. Scurvy, rickets. You should know clearly what are the radiological signs. Zone of rarefaction, ground glass appearance, Frankel's white line in metaphysis. They're all scorbutic features. Whereas cupping and fraying is a feature of rickets. In rickets, you get protruding forehead, Pigeon chest, depressed ribs, enlarged epiphysis, curved radius, curved femur, curved tibia, enlarged effaced ankle, all this. So this is subperiosteal hemorrhage, scorbutic zone, and dense zone of provisional calcification. And this is the ring epiphysis, So these are all the features of the scurvy. All right. So congenital hypothyroidism commonly is due to the thyroid dysgenesis. Weight loss in children, severe dehydration. What is the definition? More than 6% loss. So always assessment of dehydration, most repeated high yield MCQ for the NEETPG, right? So mild means less than 5% in infant and less than 3% in older children. Moderate 5 to 10% infant, 6% in older children. And severe more than 10% infant and more than 6% in older children. So you have to mug up these points. Recurrent seizures, tachycardia, S3 gallop. S3 gallop means S3 gallop, S4 gallop. We discussed earlier, no? S3 means ventricular failure. S4 means non-compliant stiff ventricle. which is seen with hypertrophy of ventricle. So S3 gallop is there, means congestive heart failure is there, with tachycardia, with lot of bruit on the anterior fontanelle. So what is your diagnosis? That is called vein of Galen malformation. Because of this vein of Galen, a lot of blood become sequestered, due to which there is a failure, heart failure, vein of Galen. So this is a typical presenting feature. 7-day-old neonate presenting with seizures, with CHF, with bruit on the anterior fontanelle. If you put a stethoscope here, you will listen the bruit in this pool of blood, vein of Galen malformation. Fatty liver in kwashiorkor, because of the lipoprotein carrier. Kwashiorkor is protein deficiency. Lipoprotein require protein component. If that is deficient, then the lipid become deposited in the liver, leading to fatty liver. Donovan bodies, granuloma inguinal, keratoderma blemoragica. These typical lesions are feature of Reiter's reactive arthritis. Right? Then Wickham striae, that lacy pattern, net-like lacy pattern on the inner buccal mucosa is a feature of lichen planus. So you remember lichen planus may 8 P's. P, it is a papulosquamous disorder. Lesions are pruritic. They are plain topped. They are polyangular, purple-colored papules and plaques, and pigmentation after healing with the pterygium in the nails. 8 P's about lichen planus. These things, no second thought in exam hall. Dermatology में 5 questions, 5 को 5 mark के आना निकलना. Right? If you are not, say, dermatology, similarly anesthesia. What is there in anesthesia? Local anesthetics, general anesthetics, muscle relaxants, and some other blah 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 things like Mapleson system, type 1, type 2, type A, type B, and all that. Some stupid content will be there, no? Totally not more than 1,000-1,500 points. We'll master it. Indurated seminal vesicle. Seminal vesicle is indurated, means think of TB. Melanocytes originate from neural crest cells. Carbon monoxide is least produced by sevoflurane. Which anesthetic is safest in children? Children means Sishu. Okay? Sishu mein sevoflurane is safe. Sevoflurane is safe in Sishu. Is some stupid way to remember. Anesthesia is all these stupid mnemonics only. Some way or other you should remember. Halothane and sevoflurane do produce carbon monoxide. Desflurane produces with soda lime. Least amount means sevoflurane. Most cardiotoxic local anesthetic is bupivacaine. Bupivacaine is most cardiotoxic. B for C. B will kill C. C is cardiotoxic. B is bupivacaine. CNS activity is not impaired by isoflurane is safe. It doesn't affect the CNS activity. That's what you need to remember. So how will you remember? Is there any way to remember? I is intracranial. So isoflurane is safe for intracranial. That is CNS activity. Mendelssohn syndrome means what? Whenever a pregnant woman comes and you happen to quickly for cesarean, if you happen to try to do anesthesia, what will happen? All the gastric contents get aspirated. That's the reason what will you do? Salix maneuver. You will press on the cricoid while doing the intubation to prevent aspiration, which is called Mendelssohn's, is what you need to remember, which is chemical pneumonitis with aspiration, especially during pregnancy. In spinal anesthesia, where is drug deposited? Between pia and arachnoid is what? In subarachnoid space. Bragg's peak is found in proton beam. What is Bragg's peak? When the alpha waves are all protons. When the alpha waves are passing, they lose energy. So the length of the path and the loss of the energy, if you take, you get what is called Bragg's peak. So it is for Bragg's peak. What is the importance of Bragg's peak? You want to give focused radiotherapy using ionizing radiation to a tumor without affecting the normal healthy surrounding tissues. Then from how far you need to send the beam so that it will be very focused when it hits the target tissue. That's where Bragg's peak is being used. Raised intracranial tension, if it is there, what you get? Sutures become separated. Sutural diastasis is the earliest sign. Chronically, if the ICT is raised, then what do you get? Increased convolutional marks on the inner surface of the skull. That's called copper beating of the skull vault is what you come across. Drooping water lily sign. This is like a drooping water lily. Whenever there is any superior pole renal mass, that will cause the pelvic ileal system to become drooped like a water lily. Cold lesion on the bone scan implicate there are metastasis. It's a rare presentation, but it is a presentation. Technetium labeled RBC scintigraphy. Where do we use? Whenever some elderly man is there, he has angiodysplasia and he is continuously bleeding. You have done colonoscopy, not able to find the source of bleeding. Then you will use technetium labeled RBC scintigraphy to identify the GI bleeding, especially angiodysplastic lesions, which are the source of bleeding in elderly people. Post-traumatic stress disorder is, what is that? Recollection of events. Like, if we fail in the NEETPG after the results come, we'll be thinking about how much tension I felt. All that when you restart your preparation after NEETPG. Then you will remember also how I wasted my time, right? So that will be causing more tension, right? Brooding followed by homicidal tendency. It's called run amok. A run amok guy will take the knife and then start running and then stabbing everybody on the way. That's called run amok. So they are called culture syndromes. There's a brief period of episodic violence marked by brooding, like Jatra. He get Punakam, then take the knife and start stabbing. Typically, it is seen in Philippines and Papua New Guinea in Australia. Then Baufi delirante is a brief period of psychotic symptoms with marked agitation, auditory visual hallucination in West Africa. See, whether it is Africa or whether it is Satyanapalli or whether it is Amalapuram, psychosis is psychosis, right? In our mythology, they say, when Krishna is born, Kamsa has ordered to kill all the children in the Pashula Paka. Same story will be created in the West. When the Christ is born, the Jews have ordered to kill the baby in the shepherd house. People think same story to write books, right? So NEETPG examiner also, every entrance will use the same story. Do you know Partha? Do you know little? Do you know gentleman? Right? Then Dhart syndrome means what? There's an anxiety over the loss of semen by masturbation or in urine and attribution of the somatic symptoms is called Dhart syndrome. Commonly because of the young males with poor sexual knowledge. So we used to have one homeopathy doctor opposite Kakatiya Medical College. So one of the junior, he's now a top endocrinologist. He got a doubt that his masturbation is bad. So he went to him. So that guy told him that for every drop of semen you are dropping, 1 liter of blood is corrupted. So that fellow got into a psychosis about the masturbation. And not only that, he started spreading the news to the whole batch. Right? So Dhart syndrome. Then Koro means sudden onset of anxiety on a belief that one's penis is shrinking and receding into the body, ultimately leading to death. So people have different challenges. Some people will constantly think their nose is abnormal. 100 times you tell nose is good, they continuously say, doctor, something can be done for this nose, doctor. They come for BP treatment and ultimately talk about the nose. General medicine doctor means it is too general, right? So kleptomania, there is a fear before stealing. Obsession will be there. Common in females, irresistible desire to steal, but the things that they steal are very inconspicuous. We used to have one casualty medical officer when we were doing MBBS. He has a severe kleptomania. We used to be careful to save our stethoscopes. Every new batch of house surgeons were losing small things. Girls were losing their pins and small things in duty room. We throw the purse and all that, bag and all that. So one or the other item used to be lost. Finally, they caught him, and all items were found in the room. So, but they're all inconspicuous. He can't do anything with a something like a lipstick. What will he do, right? But he'll get the tension. Let me take that lipstick, and then he'll pick it up. Kleptomaniac. So cataplexy means what? Sudden loss of muscle tone. See, when we are sleeping, when we enter into REM sleep, then we lose muscle tone. That's normal. But few people suddenly lose the muscle tone without entering into that REM phase. That's called cataplexy. So sudden involuntary loss of muscle tone without loss of consciousness. And what precipitates this atonic phases? It is the emotional outburst, like laughing, crying, suddenly they will fall down. If you have one such girlfriend, it will be a fun. For every joke of you, she will fall down. So if you say, I want a girl who will fall for my sense of humor, then marry a cataplexic girl who will be falling down every time you throw a joke. Then what are the causes of cataplexy? Hypocretin deficiency. Hypocretin is a neurotransmitter hypothalamus that regulates your arousal level and your muscle tone. And any hypothalamic or brainstem lesions can lead to cataplexy. Any sudden withdrawal of SSRIs can lead to cataplexy. So what is tetrad of narcolepsy? Narcolepsy में 4 चीजें होते हैं. Cataplexy, automatism, sleep paralysis, and hypnagogic hallucinations. These 4 constitute the tetrad of narcolepsy. Cataplexy, automatism, sleep paralysis, hypnagogic hallucination. The combination is what you need to remember. Now, what is an indication for ECT, electroconvulsive therapy in a depressed patient? Any depressed patient with suicidal tendency is the indication for ECT. Vesical fistula. So whenever from the colon into vesical bladder you have a path, then air in the colon will go into the bladder and along with the urine you get air bubbles, pneumaturia. is the presenting feature. Hypertrophic pyloric stenosis, what will you see? You find hypokalemic, hypochloremic metabolic alkalosis in hypertrophic pyloric stenosis. भैया क्यों होता है? So let's come back quickly on this. Hypertrophic pyloric stenosis. What is happening in hypertrophic pyloric stenosis? There is stomach, pyloric end, and there is a stenosis there. So food is coming from esophagus into stomach, and it is unable to negotiate into duodenum. All that is accumulated over here, and then it is getting vomited. So as you are continuously vomiting from stomach, you become hypovolemic. Child become hypovolemic. Hypovolemia lead to decreased plasma volume. That lead to decreased renal plasma flow. That lead to increased adrenaline. That lead to increased aldosterone. That lead to retention of sodium, loss of potassium, loss of H+. So, what do you get? Hypokalemic, hypochloremic, metabolic alkalosis, which is due to hypovolemia caused by continuous vomiting. Right? And H+ is lost into urine. Why this is called paradoxical aciduria? Paradoxical aciduria क्यों बोलते हैं? What is that which is vomited by a pyloric stenosis baby? The contents of stomach which are acidic. When you are vomiting acid, what is your body expected to? Retain acid and should not throw the acid in urine. But here what is happening? H+ is lost into urine due to secondary hyperaldosteronism. That is the reason this H+ loss into urine, the aciduria, is called paradoxical aciduria because the guy is vomiting acid and also losing acid into urine. That's what you need to remember. What is the least common volvulus site in neonate? Small bowel, gastric volvulus, ilioiliac, they're all common. Colonic is very rare. Gardner syndrome. What is Gardner syndrome? Desmoid tumor. You can see this is the classical example of a Gardner's tumors. Gardner syndrome's desmoid tumor. So, autosomal dominant syndrome with adenomatous polyps, osteomas, and soft tissue tumor like desmoid tumor. The combination is called Gardner syndrome is what you need to remember. Whenever biliary obstruction is there, what will you do? You do ultrasound. First, CBD dilatation. Common bile duct dilatation, if it is documented, then you will go to everything else. Whenever there is a jaundice and symptoms of obstructive jaundice. Pneumoperitoneum, what is the investigation? CT abdomen. See. In CT abdomen, what do you see? Here. You can see the gas. Very sensitive to detect pneumoperitoneum. CT abdomen is the investigation of choice. Upright chest radiograph can detect as little as 1 ml. Lateral decubitus abdominal radiograph can detect as little as 5 to 10 ml of gas. That's what you need to remember. Then once more, what are the radiological signs of pneumoperitoneum? We need to master. I'll leave the literature for you. Just review that. All this Wriggler sign, football sign, cupola sign. What you do, no? Radiology never read alone. Open your Google images. See how a Wriggler sign look, football sign look, cupola sign look. Everything is there on the Google. Right? Nothing to imagine. Radiology especially. Actual radiologists only are going to the Google and checking. One of my friends is a top radiologist. He says, अरे सब कुछ अवेलेबल है रे गूगल में, कोई टीच करने की जरूरत है क्या? इसके लिए एक बड़ा ऑल इंडिया इंस्टीट्यूट श्री चित्रा तिरुमल जाके एमडी रेडियोलॉजी करने का जरूरत कुछ भी नहीं है। गूगल पकड़ो और Ellaya, Buchaya Medical College also, you can become MD Radiology. Only you need to keep on learning, and clinically correlate. A chronic alcoholic with regurgitation, retrosternal pain, Barrett's esophagus is there. So what is the most appropriate management? First, Barrett's esophagus can become adenocarcinoma every 2 years, endoscopic biopsy. And also you need to give proton pump inhibitors as a part of the treatment. Follicular carcinoma of the thyroid. Typically, FNAC is not diagnostic. You know that funda, I think. Papillary, follicular, medullary carcinomas are there, doctor. If you do FNAC, what are you getting? FNAC is different from biopsy, right? So, follicular adenoma and follicular carcinoma, both will have same dysplastic cells. How do you differentiate adenoma or carcinoma? If you do biopsy, then if the capsular invasion is there, then you call carcinoma. And can you see capsular invasion in FNAC? No. So FNAC is not diagnostic in, because you can't see capsular invasion, not diagnostic in follicular carcinoma. Papillary carcinoma can be multifocal, not follicular. Papillary carcinoma can go to lymph node, not follicular. So you should know all differences between follicular and papillary. Which hernia is prone to recur after you do primary repair? Incisional hernia. Then what provides strength whenever you do, tomorrow colon cancer patient came, you resected that segment which is having colon cancer. Remaining parts of the colon you joined together. That's called anastomosis. So how will anastomosis will have a strength? It is the submucosa that provide the anastomotic strength, is what you need to remember. Benign small bowel tumors, they can lead to hemorrhage, they are asymptomatic, accidentally discovered. That's what you need to basically remember. Right, doctor? Now, grading of the burns. What do you mean by grade 2 burn? Grade 2 burn means involvement of dermis. First degree is only localized epidermis. In that you have second degree. Superficial second degree, deep second degree. Superficial second degree means epidermis and superficial dermis. Deep second degree means epidermis and deep dermis. Third degree is full thickness. Fourth degree is subcutaneous fat and underlying muscle or bone, is what you need to remember. Then about medullary carcinoma of the thyroid. It produces calcitonin, arised from C cells, and medullary carcinoma can be part of Men's syndrome. Whenever it is a part of Men's syndrome, we do in the first degree relatives prophylactic thyroidectomy if that MEN gene is being found, even before the origin of the thyroid cancer. That's the point. So, doctor, last 6 questions. 1:30 we will call. Next week our stamina will come back. We'll reach 150. Slowly we will improve. First only we are like this means too much. Remaining anyway, you have the literature. Carpal tunnel syndrome is a feature of hypo, not hyperthyroidism, is what you need to remember. You are palpating hepatoduodenal ligament. So, what do you feel inside it? It's called Pingley's maneuver. Pingley's maneuver. So this is called foramen of Winslow. Whenever you are approaching foramen of Winslow, you need to clamp on the hepatoduodenal ligament, so that here there will be a replaced right hepatic artery. So what is the meaning of replaced right hepatic artery? It is a variation of hepatic artery. If the right hepatic artery arises from superior mesenteric artery, then that is called replaced right hepatic artery, which can be caught in hepatoduodenal ligament. All right, doctor. Then replaced left hepatic artery means it originates from left gastric artery, and you can identify it in gastrohepatic ligament between stomach and liver. Gallbladder causes absorption of water, sodium chloride, secretion of H+, not the conjugated bile acids. That is not the function. Black pigment, brown pigment. Black pigment means if you have hemolysis. Then the hemolysis, then hemoglobin is released. That lead to black pigment stones. Then brown pigment is whenever there is any infection, then that lead to brown pigment gallstones. Gallstone is stone in gallbladder. And cholelithiasis means bile duct. Cholecystitis, cholelithiasis means the bile duct. So black pigment gallstones are commonly because of hemolysis or cirrhosis. Brown pigment gallstones are commonly because of the stasis and infection. That's the point. And all differences between the two, you have to be very sure about. In gallstone disease, what do you see? There is a shadowing posterior, right? And that stone will show mobility with respiratory movement and a hyperechoic intraluminal structure. These are all the features of gallstones, basically. Then 50-year-old ultrasound imaging, you have seen this. So what is this, doctor? This is the shadow which is being thrown by the stone. So what is the recommended treatment? Asymptomatic gallstone. In a 50-year-old woman, what do you want to do? Asymptomatic cholelithiasis. Cholelithiasis is in the gallstone, gallbladder, right? Is observation. There are only few indications where asymptomatic gallstones who are incidentally found when you are doing ultrasound, when to be treated. There is a list of indications. We'll discuss that. Now, acute cholecystitis, if you want to diagnose, what is the best way? HIDA, PIPIDA and HIDA scan for acute cholecystitis. So many times this question has been asked. Radionuclide scanning. All right, doctor. So with that, let us call it a day. And thank you so much for patiently online. We have 4 online students. Thanks for patiently following up this long marathon of 2 hours, 10 minutes. Not bad, eh? Yeah. At 50 and 25. Thank you very much. Thanks for coming. And tomorrow, once more, we'll have class at 6 o'clock. Try to come at 12, 1 or 1:30 once you finish your lunch. And then nicely study. One session either, one session room mein. Right? Or even morning 10 o'clock, they will open. You can come and study. Right, doctor? Slowly, this logging in the reading room and everyday evening class becomes a habit. And then as out of 60,000 points, first 10,000 points revision hote hi, you will get a ring, Buddha ring. Confidence will change. Then 20,000 points, bigger ring. Then by 40,000 points, you get nirvana. You are jnani, right? By 60,000 points, you can start a new coaching center, right? Thank you very much.